So today we've got Dr. Chris Hebbs, is one of the intensivists at the Royal, talking about traumatic brain injury, and Hina, I think, and Vincent talking about some radiology teaching at the same time. So that would be really good. So make a start.
Yep. So hi, my name's Hina. I'm clinical teaching fellow for radiology. Dr. Lamb's with us too, our neuroradiologist, and he's helped put this presentation together. So we're looking at trauma on CT heads, so I think that was the topic of today. So we'll make it interactive, and I have a few cases to work through together. So we're going to go through some of the guidelines. I'm going to whiz through those because I'm pretty sure you all know them and have access to them. I'll briefly go over orientation so we all know what we're looking at when we go through the rest of the cases, and then we'll go through a few of the cases on traumatic brain injury. Okay, so these are our nice guidelines which we use in UHL as well. And you've got two sets of guidelines, one's for CT head within 1 hour and one's for CT head within 8 hours. And I'm pretty sure that you all have access to these and know these as well. So I'm going to open this to the floor. These are the 3 planes that we usually use in radiology to go through different imaging. And as most of you probably know, that we use at least 2 planes to see anything, particularly on plane films, 3 when it comes to CT and MRI. So anyone want to take a guess as to what some of these planes are called and which way they're taken through? All right, so if we start with the first picture, which is on the far left on the screen, it's taken horizontally through the brain. So we're just taking a slice like this. Anyone want to shout out the name for a horizontal slice?
You guys feel free to unmute yourselves and to chip in. It's supposed to be an interactive session.
Join in, people. Sounds like a trainee question to me.
Axial.
Brilliant. Yes, axial. So our middle is taken vertically through, and so what's that going to be called? We'll take it straight down. Yep. And then our third one is going to go right through the middle of the brain, and so what's that one going to call?
Sagittal.
Correct. Yep. Ready? So we'll go straight into our first case. You have a 74-year-old. They're found on the floor, unresponsive and in a care home. They're not responding appropriately after 2 hours and they've got low GCS. You have 2 images here. You've got the axial image on the left and then the coronal image on the right. Can someone describe to me what you're seeing?
Subdural.
Fantastic, yes. So all of this that we're seeing, collection, hyperdense, and it's completely white compared to the actual grey, the grey matter next to it, which is the brain, and that's a hemorrhage collection, which is subdural. I meant to show you this one, but yeah, you've got the correct answer. So also, can you tell me what else is happening on this picture?
There's a midline shift and there's a loss of the ventricular spaces as well, signifying that there's a significant loss of increased pressure in the brain.
Yeah, fantastic. So you've got loss of your ventricles on the left side here, so you're unable to see it. You've got asymmetry. You've got a shift in the midline, and that's got some parathalcine herniation coming through. You've also got dilation of your ventricles here. So the dilation of the ventricles with the absence on the opposite side would suggest that you've got hydrocephalus, and that would become a neurosurgical emergency and hence referral to the neurosurgical team. So Sometimes you can get subdurals which are quite small and the only finding will be a subdural collection, but there are other times when that subdural will cause a lot of effacement and mass effect on your surrounding structures, and that's what you've got to be really careful about. So we'll just talk a bit about the location of the subdural. So this usually happens between the arachnoid and the duromater. So you can just see that through here. So this red over here is your subdural, and it opens up the space in between it. This is often due to a vein that's ruptured into that space, and therefore it can be quite a slow growing collection that occurs. We tend to see in normal practice, sometimes people have had falls and they've come over a week or two later and then they've developed subdural hemorrhage that's caused mass effect, causing them to have symptoms. So a couple of the imaging features is this crescentic shape when you see it on a CT. And it can cross your sutures, but it's limited to your falx and tentorium. I can show you that if I go back to that picture, it doesn't go past the falx, and so it stays there. And you can just see it on the axial image as well. It comes across to the falx here, but it doesn't go across to the opposite side. So case number 2. You have a 35-year-old male assaulted, unable to recall events, and there's a head injury visible on the left side. They've got a hematoma and swelling, they're intoxicated, and their GCS is 14 out of 15. So this is an axial image of their CT head, and I'm just going to zoom up for you guys to focus on one particular area. So I want you to look at these 2 images in particular, and I'll give you a few seconds before we go through what this might be.
Subdural, there is.
Yep, that's correct. So this is an epidural or an extradural collection. And you can see it biconvex, nice and small one. And can anyone tell me what's associated with this epidural collection?
Skull fracture.
Yeah, so just as the other arrow is pointing, there's a skull fracture just there. And so skull fractures are most commonly seen with extradural hematomas. They're not usually seen with your subdural ones. And so it's always important to look for that to make sure you're not missing a skull fracture. So the difference between the 2, the extradural hemorrhage is usually between the skull and the duromater. So if you just have a look on the diagram here, there's the dura that's being pushed inside, and then you have your collection for your extradural just outside of that. It's often because of a laceration of an artery, and the most common one is your middle meningeal artery. However, it can happen from some of the bridging veins as well. So this one's slightly different in that it's a biconvex shape, and it's limited by the sutures rather than the falx. So this image is just show you the differences between the 2 that we've just seen, particularly in their shapes. So this is a similar case. So this is a 6-year-old who fell down 13 steps and they've hit the occipital area. They're vomiting, they've got a headache, and they've got a scalp hematoma. What type of bleed do you think we can see here?
Tabarak, this one, or?
Any other ideas?
Or still epidural?
Yeah, fantastic. So it's an extradural as well. So you've got your biconvex shape, and that gives it away. The subarachnoid, what layer would you expect to have a subarachnoid hemorrhage in? Sorry, I think I might have missed that. What layer was would you expect to have your subarachnoid hemorrhage in?
In the brain of, after the arachnoid layer.
Yeah, so it'll be in the subarachnoid space, which is in the arachnoid and pia mater, and it's a space that's then created. So we'll have a look at that case as well. So this one's our EDH. But before we move to the next case, we just want to discuss a complication that can be seen in extradural hemorrhages. So this is the same patient. This is a few slices lower down on the CT head. And what we see here is a fracture, underlying fracture. And that fracture has continued inferiorly, and it's caused what we call a hyperdense sign at the venous sinus venous sinus. And we've then gone and done a venogram, and that's shown a venous sinus thrombosis. So you can see the difference in the left and the right. The left is opacified with contrast, and the right is non-opacified. So even though we can get extradurals as initial presentation, they can have complications, and that could include a venous sinus thrombosis. So it's worth keeping that in mind in terms of management. And I've given you the answer. Okay, case 3. So you have a 30-year-old male. They're hit on the head by a car door 4 days ago. They're vomiting. They've got severe headache and left side of and pain at the left side of the neck. There's no neurological deficit. I'm going to give you some time to look at these 4 images. They're all in different planes, and I want you to think about what you're seeing in here before we go to the next question. Okay, I'm going to take you guys to the next question. So which of these is not present on this case?
E, ruptured aneurysm.
Fantastic, yes. So let's go through what we're seeing on these pictures. So does someone want to name the first finding? If I point out to this area here, what are we seeing here?
Epidural, this one.
Yep, and corresponding to that extradural, what are you seeing on your bone windows?
Fracture.
Yep, and in addition to the fracture?
Pocket of air.
Yes, fantastic. So one of the most important things is pneumocephalus. Any pockets of air that we can see intracranially usually always indicate that there's an underlying fracture somewhere. So if you've seen a pocket of air, you need to search very, very carefully that actually there is a fracture somewhere. So that's very well done. And then someone described to me what they're seeing in this area here.
So there's a subdural and there's intraparenchymal bleed, which probably is contracup injury.
Fantastic, yes. So I'll just outline the subdural first. The subdural is just along right close to the edge. So quite a shallow subdural that we can see. And then, as you've correctly said, a contracup injury, which is intraparenchymal hemorrhage that we can see here. And what you can see outlining the hyperdense, the white material, is a bit of edema, which is the black surrounding it. And so our next slide, we'll talk about contracup injury. So cup and contracup injury. So as we saw on the previous slide, there was hit on the right side, you had the extradural, and on the completely opposite side, you had the intraparenchymal contusion. So at opposite ends. So when we look at cup and contracup, you have that essentially in all types of injury. So you have the site of injury where you have acceleration from initially you have the skull that carries on going forward, and that's where the first blow is taken, and then as the skull stops, the brain is already traveling forward, but it hits the skull at a high speed and before it stops, and that causes your contracup injury with the contusions in the parenchyma. Any questions on contracup and cup injury? Okay, we'll move on to our next case. Well, actually, we'll talk more about that one anyway. So why is it important to talk about contra-group and group injury? Well, it's important to know that actually where the site of the injury is, you should be looking for additional findings in the surrounding space. So over here, we can see there's a small scalp hematoma, few bubbles of gas. And then as we go further inside the brain, actually there is a small focus of intraparenchymal contusion. So it's important to look at where the initial site of the injury was, and then the contra-group aspect as well, to make sure you're not missing out any additional findings. So this is an interesting case that we had, which shows extensive pneumocephalus. And in this case, it kind of outlines the brain as being slightly shrinking in size, but I think that it's just the air taking more space. And then other fractures that we usually tend to worry about. So these are petrous bone fractures. Our top case shows a transverse fracture, which is through the posterior semicircular canal, sorry, adjacent to the posterior semicircular canal. And we worry about some of these because depending on what structures they go through are going to give you different symptoms in life. So if we go further down, when you're going through the posterior circular canal, you'll probably have symptoms such as vertigo. And then if we go further down, we have ossicle disruption, which would give you conduction deafness. So it's important to figure out exactly where your fracture is and what structures they're going through. Petrous bones can have longitudinal or transverse fractures. Longitudinal fractures are the most common fractures to have. However, if you have transverse fractures, you worry about causing a facial nerve palsy because the facial nerve runs through the petrous bones. Similarly, if you fracture more medially, you then worry about hitting the jugular vein, and that can cause you other issues which will lead to having a CT angiogram. So any fractures that you've noted that might be in the petrous bone and that's medial, you should always ask for a CT angiogram to assess the vasculature around it. So case 4. So this is a 48-year-old male who's had an RTC with a GCS of 12. Day 1. Can anyone tell me what they're seeing that's circulated around in red?
Contusion or?
Yeah, fantastic. Yeah, so it's a contusion, and you can just subtly see that there's a little bit of hypoattenuation surrounding it, which would be edema. There is another finding on this slice on the right-hand side. And you want to tell me what this might be?
Is it another contusion?
It's not a contusion this time, but it is something that's been mentioned earlier on from the audience.
Subarach.
Yeah, fantastic. This is subarach. It's difficult to see it on one slice, and if you had more slices to scroll through, you'd be able to see the linear going through the sulcus, and that would make it a subarach. So 15 days later, as you know, we have handy time of comparison, which makes life a lot easier in radiology. The contusion itself has resolved. However, the edema around it remains, and so this effect will remain and stay with the patient. So just continuing on this, does anyone tell me what they think of this CT? This is taken 15 days after the accident. Okay, it's a slight trick question. There's no abnormality you can see as such. But I only say this because when we go ahead and do the MRI, there are multiple abnormalities that we can find. So the MRI and the CT are taken at the same slices so we can have a comparison. And on the MRI, we can see this is a susceptibility weighting image, and there are a lot of small areas of blackness. either peripherally or more centrally where the corpus callosum lies. And these are all sort of microhemorrhages from diffuse axonal injury, which is something that you cannot pick up on CT as it looks normal, but needs to have an MRI. So there should be a clinical indication or clinical inkling for this sort of condition when you're worried, and we can do an MRI to help with that. The second image also shows contusions in your predicted areas when you have conjugate injuries in the inferior frontal and anterior temporal lobes. And these all cannot be seen on your CT that you're seeing. So just something to be aware about.
Yeah, so we have done the MRI and the other CT just because still the patient had low GCS, so there is another findings.
Yeah. So case 5, 73-year-old fell down 7 sets of stairs. If you have a few seconds to take a look at these 3 images, and then I'll ask you what you can see in them. Okay, what findings were on the images? I'll bring them back on for you, and then you can talk me through what you're seeing. Although I've not managed to go back on my page and given you the answer. Oh, there we go. Okay, talk me through what you're seeing. So we'll start off in the bone window on the far right.
Yeah, there is a fracture in the area.
And scalp hematoma.
Yep, fantastic. We'll go into the middle one next. What are we seeing on this image?
Contusions.
Yep. And then what are we seeing on our first image?
The subarak.
Yeah, so you can see they're quite nice and linear, and they follow the sulcus. Brilliant. So we've gone through a summary of the guidelines, understanding orientation that we take, and then reviewed a few of the common cases for traumatic brain injury. Any questions?
Don't seem to be any, Hina.
Nope. Probably put them all to sleep after they've had lunch.
Maybe. These are the kinds of things we see quite often at the Royal. They come in through A&E on a regular basis, and you will be asked to go down and see them and support them from an airway point of view quite often. And either they get transferred to Queen's if they've got other trauma, or they come up to us.
You might also get asked to assess their suitability for transfer and whether they need intubation or airway management prior to transfer as well, which can be quite a difficult decision sometimes.
Yeah, and sometimes you can escort the patient to CT without putting a tube in. I do that sometimes as well.
Absolutely, and I think we're going to talk a little bit more about management in the next section, and also some of the guidance around transfer, because that's a bit of a hot topic, and it can sometimes be a bit of a flashpoint between ED and ourselves.
Yep. Imaging doesn't always fit with clinical picture. That's the only other thing I'd say. People can have a fairly normal CT and have a fairly horrendous brain injury, and they can have a fairly horrible looking CT and actually be pretty normal.
Definitely agree with that. I think sometimes I think probably the most valuable thing I usually say to the families early on is initially that there are unfortunately no tests that can tell us how the patient is going to be. The CT gives us a bit about structure, but it doesn't tell us function. And the best test is when we can get the patient to the point of turning the station off and seeing how they are. And that from our point of view, that sometimes gives the families a little bit of time to come to terms and to think about without giving false hope, because we're not beating around the bush. We genuinely don't know until we patient down.
Well, my CT and MRI looked pretty crap 2 months ago, apparently. So I'm all right now. Right, should we move on then? Sorry, go on.
Hannah had a question in the chat box. So Hannah's question was whether intubation could worsen intracranial pressure. Yes, it can, particularly if it's not done carefully, and therefore you have to think about the ways in which you manipulate the airway, any movements of the head and neck, and also consider the drugs that you use to try and reduce that impact. And that's quite a common exam question. And there are particular drugs that you might use in that situation to help reduce the pressure effect from laryngoscopy. Things like alfentanil or other opiates can be useful.
Yeah, use things that you're familiar with is what I'd say. Don't use drugs just because you think they're the right thing to use, but you've never actually used them before.
Absolutely, and get some
just use them carefully.
Okay, so in terms of overall objectives for the entire session, we're hoping that by the end you should be able to describe the findings on cerebral imaging of traumatic brain injury, including the common findings of hemorrhage, cerebral hypoxia, diffuse axonal injury, and pneumocephalus. And hopefully after Hina's presentation, you've seen those images and you'll be able to recognise some of the salient points. And yeah, I think Hina gave a really good overview of some of the important issues. And if you're in CT looking at a patient with one eye and with one eye on the monitor, you might also catch some of those findings. So hopefully we've covered the first objective. My part of the session is about describing the principles of management of patients who are at risk of neurological injury, and that sort of correlates very nicely to the high-level learning outcomes for ICM, but it also cross-covers many of the outcomes for ACCS as well. So hopefully this should cover an area of your curriculum, whichever curriculum you happen to be on. So for my presentation, so I'm Chris Ebbs, I'm one of the consultants in anaesthesia and intensive care at the Royal, and I'm going to talk about management of traumatic brain injury. I'm first going to talk about what a traumatic brain injury is and where it fits within the general focus of trauma. I'm going to talk about management of brain injury, and then some controversies and opinions and some of the evidence in studies. And then finally, I think a talk on traumatic brain injury isn't complete without talking a little bit about prognostication and how we work out how someone's going to do. And as we've just alluded to, the imaging doesn't always tell the whole story, which is why we admit a lot of these patients. And on the face of it, people sometimes turn around and say, well, why on earth did we admit that patient? Hopefully prognostication will give you some indication of what we're thinking when we do that. So as part of your training and curriculum, some of you will have done ATLS. It's a little bit old hat, and some of you might have done the more modern European trauma course or the ATTACK course. Those courses tend to talk about a triphasic model of trauma, in that there are a group of patients in whom, however good their care is, they won't survive. So this is the group of patients really who were dead before you even got to the scene. And the only intervention that can help those patients is having worn their helmet or having worn their seatbelt, or laws to reduce speeding. There are two other groups that we can effect a change in. So there's a sort of mid-term peak in mortality, and that group of patients can be affected by changes that happen within the first hour. And we talk about the first hour in trauma as the golden hour. And really in the context of head trauma, that's your intervention to intubate and stabilise that patient. So intubating a patient with a traumatic brain injury and doing it well and preventing the changes that can cause secondary brain injury is really important, because that affects the mortality of the patient, but also the longer term outlook of the patient. And then talking about the sort of triphasic, the third peak of mortality, that's your patients who've survived They perhaps even got out of hospital, but they've got a low GCS and ongoing disability, and they then end up with things like venous thromboembolic disease. They end up aspirating, and they have other complications that then cause them to die. So the sort of take-home summary is there are some people who die initially, and you can't do anything about those. There are patients who die in the mid to late term, who I think early intervention in an appropriate way is really, really important, and we can do some good and make a difference. Trauma is a leading cause of disability in the under 40. So that's people who perhaps don't know better and drive fast in cars and that sort of thing. It affects the young and the old. So, young people drinking, driving, speeding, that sort of thing, and older people, perhaps frailer people who don't have the bone strength that younger people do, falling over and hurting themselves. And by the time you're in the perhaps 40 to 70 age group, you're probably old enough to do better, and you've still got strong bones. A brain injury is any injury that causes a dysfunction in the functioning of the brain. It's a really, really wide definition, and it covers a broad spectrum of different types of injuries. We'll classify it according to the GCS, which, as I'm sure you'll all know, is a bit of a varied scale, and it certainly can be interpreted differently by people. And so there's a spectrum of scores for the same patient. GCS should always be the best GCS that you can attain from that patient, and it may fluctuate over time. The reason I'm putting this here is that it is potentially a prognosticating factor, and your neurosurgeons will want to know what's going on with the GCS when they make their decision about whether they're going to offer neurosurgery or not to that patient. So, nice simple scale. We classify either as mild, moderate, or severe, based on the GCS, and that information is going to be important to hand over to the neurosurgeons. The other thing that you're going to want to know as well in terms of classifying is your pupillary responses. So that's, again, something to think about before you intubate the patient and give them a muscle relaxant, and then unable to assess those things. Whenever you're taking an exam focus, we talk about general and specific scoring systems. So the GCS is it's a neurological system, but there are a number of different scoring systems for different conditions. I'm highlighting subarachnoid hemorrhage in detail because there are some specific scoring systems for that, and for those of you doing the FICM exam, these definitely do come up. So there are three just for subarachnoid hemorrhage: the Hunt and Hess scale, the WFNS scale, and the Fisher scale, which is a CT imaging scale based on CT findings. So just to give an example of that and the link between some of these scales and prognosis, the WFNS scale is, as I said, the scale used in subarachnoid. It's a clinical scale, so it's based on the symptoms and the presentation of the patient, and it links directly to the estimated survival. So if you think about a surgeon deciding on whether they're going to offer operative intervention to that patient, they're going to want to know how the patient presented. So a good history and a clear examination when you go and see that patient is really, really important, because it has an effect on survival, but it will also have an effect on the disability of that patient. To some extent, I'd argue that survival is almost immaterial. The thing that I think really matters to the patient is disability, because for me, as an intensivist, if we leave a patient in a state worse than death, where they're significantly disabled, not able to do any of the things that they would want to do, I would argue that we've done that patient a disservice. But some of the scales are relatively crude. So the GCS is a sort of 15-point scale, mild, moderate, severe, and you've got sort of 7 or 8 point scales, and some of the other things. A lot of the evidence and research looking into longer term outcomes for traumatic brain injury looks at disability in a much more granular level. So there was a large study looking at how patients do longer term after their traumatic brain injury. And essentially, things like GCS are stable and predictive. So, for example, the black boxes, those that had initial presentation of a severe brain injury with a GCS of less than 8. So it shows the Glasgow Outcome Scale extended, and those patients who had a poor GCS and a poor outcome scale at 10 years also had similar at 20 years. So those patients that have a severe brain injury, those that survive at any rate, have a sort of stable disability, and that disability continues. And in terms of patient outcomes, that's obviously poor for the patient, but in terms of a broader economic point of view, that's really, really expensive, both to healthcare, it's expensive to the economy because those patients aren't going on to necessarily affect any meaningful change in society or change the economy. So trauma is expensive. It has a high initial death rate. I think the goal now is really important, and that's the time where we can probably effect the greatest change for those patients. And of those with a moderate or severe brain injury, they'll probably have a stable disability, but they won't necessarily be able to do the things that they want to do. So there's a significant and stable impact on that patient, but there's a much wider impact on social functioning and on the economy as well, a big cost to society. So a little bit of background to trauma. I'm going to move on now and talk a little bit about the principles of managing trauma. So you're the IT registrar, you get called down to the emergency department, and you are asked to see a patient who's had some kind of a head trauma, head injury. And we're going to talk about how you manage those. So the trauma courses will talk about the sort of ATLS principles. So going down to see a patient, airway with C-spine control, because remember, trauma has a lot of other peripheral effects and things to consider. So your patient who's perhaps hit themselves hard enough to have a brain injury may well have fractured their C-spine as well. So you have to consider that they may have a C-spine injury, they may well not be starved, there may be other injuries to think about. And then the wider point of view, is it safe to approach that patient? Luckily in the UK and at the LRI, we're relatively safe going down to ED, but if you're in a war zone, in a trauma area, you might be at risk from bullets or the knifeman that's running around. So all of your standard trauma principles apply in this situation. So, spoiler, all of the principles of managing a head injury are based really around, well, I used to think they were based around maintaining pressure, but actually it's not necessarily all about pressure. It's probably all about flow. And we're going to talk a little bit more detail about the first principles of doing that now. So I'm just going to switch to something else. Okay, so hopefully you can see my my whiteboard here. Okay, so a lot of the principles of managing head trauma are based around something called the Monroe-Kelly doctrine. And the Monroe-Kelly doctrine is that the brain is in the skull, which is a fixed box. So I'll put my skull on here. So that's the skull, that's the fixed box, and you can put stuff into it, you can take stuff out of it, but you can't expand that rigid casing that you've got there. That's the skull. And you've got your brain in there, of course, as well, which is sitting here. So the brain sits in the middle of the skull there. But you've got a few other things here. So you've got blood and CSF. And the things that determine the pressure within that box, within that skull, are the inflow to that skull. And the inflow to that skull is dependent on the pressure. So it's dependent on the mean arterial pressure. And that is blood pressure, which is dependent on heart rate and stroke volume. In terms of the outflow from that skull, that's restricted by the CVP, venous pressure. So in terms of preventing secondary brain injury and preventing the pressure from increasing within the skull, you've got a few things that you can actually do. So if you want to improve blood flow, you can do a few things to reduce your CVP. So thinking about the guidance for trauma, we can sit our patient up. We can avoid using tight neckties, which put pressure on the venous circulation, and we can improve the outflow. So that should hopefully improve the amount of blood that drains from the skull and reduces the pressure in that way. We can also do a few things to improve and increase our mean arterial pressure. So generally, we use some kind of vasopressor in order to try and drive the blood forward into the central circulation. There's a few other things that we can do as well, and although you can't directly take CSF out of the brain, they can in a neurosurgical centre. They could put an external ventricular drain in, and they can drain CSF in that way. But we can't do that here. We can do a few things that influence the amount of blood in the head, if you like. So I'm just going to clear this slide. So the amount of blood in the head is dependent on the blood vessel caliber and the vasodilation or constriction of those vessels. And the vasodilation or constriction is affected predominantly by the pH and PCO2 and the PO2. So thinking about that, the important things are CO2, because CO2 effectively is a vasodilator. And when your levels increase, particularly between about 3 and about 9, you get an increase in flow. So flow's on the y-axis and PCO2 is on the x-axis. So the guidance is to keep the CO2 within a normal limit, and it's between 4.5 to 5. We used to recommend hyperventilating in order to end up down sort of this part of the curve, but actually you've got this balance between making sure you're still perfusing the brain. You don't want to be vasoconstricted too much. But there are a few other things that affect the vessel caliber as well. And if you think about the brain that's really struggling and that is very hypoxic, you want to get as much blood to that brain as possible. So if your PO2 is very low, you get massive vasodilatation too. And you get this sort of picture. So the aim is to maintain normoxia, a PO2 of above 10, in order to achieve those goals. The other thing to say about this is normally blood flow is auto-regulated within very tight limits. The injured brain doesn't do that, so the flow to the brain is directly dependent on pressure. So it's all about flow, but pressure is quite important too. So actually maintaining an adequate map is really, really important, because if that map drops too low, then we won't provide enough pressure to provide enough flow. If that map gets too high, then we'll just increase our intracranial pressure. So those are some general principles of managing PO2, PCO2, and principles of improving venous drainage. There's a few other things that we need to do to try and optimize our perfusion as well. And I'm just going to switch back now. Okay. So a few other things that we can do. So I said that when the brain's really screaming out for oxygen, you get vasodilatation. So it's really important to try and do everything you can to stop the brain getting into that state, and that's reducing the CMRO2, the cerebral metabolic rate for oxygen. And if we have a patient who's seizing, it's appropriate to treat that. These patients all used to be given anti-seizure prophylaxis. Now we tend to only treat if they're having seizures. It doesn't really matter what you give. It used to be phenytoin. We're swaying towards lamotrigine these days because it doesn't require cardiac monitoring. It's easier to draw up, and the dosing is a lot easier than phenytoin. We try and make sure the patient's adequately sedated. So that also reduces their CMRO2. So in our situation, it's a propofol infusion. Arguably, we should probably measure things like a processed EEG on these patients, but we don't have the ability to do that. But an EEG might be useful, because that would indicate whether we're burst suppressing, whether we've got adequate perfusion or not, and whether the patient's actually seizing. That's probably a hot topic, and I'm sure we'll be doing that more in the future. And the other thing we should do is to maintain normal glycemia as well. So in the same way that the brain that's very hypoxic develops vasodilatation and a high intracranial pressure. Similarly, the brain that's very hypoglycemic will do that too. Other interventions we can do to reduce the intracranial pressure are to prevent the patient from coughing. So that goes along with really making sure they're adequately sedated, and provided that they're not seizing, I think these patients should all be paralysed. They really shouldn't be coughing, spraying them in tube, and you're probably going to want to paralyse them for transfer anyway. And we talked about the other things on this slide. The only thing to say really is when we're talking about maintaining inflow, we're aiming for a MAP of above 90. And the reason we do that is your cerebral perfusion pressure is your MAP minus your intracranial pressure. We assume that in a head injured patient, your intracranial pressure is 20. So a MAP of 90 should mean that you've got a perfusing pressure of 70, which should be adequate in most patients. And in fact, there's a whole paper written on the guidance for doing this. So the Association of Anaesthetists in 2019 produced a document which will almost certainly come out in the final FRCA exam if it hasn't already. I strongly recommend reading. But one of the very useful tables in that document gives guidance for how you would manage various intracranial injuries and specifically traumatic brain injury. So as we said on the previous slide, from first principles, we're managing the blood pressure, we're managing the PCO2, which should be between 4.5 and 5, and we're aiming to maintain adequate oxygenation. So in terms of our initial management, we've talked about how we manage or prevent secondary brain injury, and secondary brain injury is probably the thing that we can effect the greatest change on. The patient's already had their primary injury, and to some extent we can't do anything about that. We're not neurosurgeons, but we can try and prevent them from coming to harm after that, and at least before they get to the neurosurgeons. So we in the chat just before I started, we said we were going to talk a little bit about guidance for transfer and when we should transfer these patients. So we're going to transfer a patient for 3 reasons really. Either to have their definitive surgery. So patients, for example, might need to have a hematoma evacuated. They may need to have other surgery to reduce the pressure in their head. So I said that the skull was a fixed box, and to all intents and purposes it is. There is an operation called so there's an operation to remove a piece of brain, which reduces the pressure in the head as well, decompressive craniectomy, and that is indicated for pretty much only MCA infarcts, but it is an option to reduce the pressure. We'll talk about that a bit later. We can sometimes transfer a patient for monitoring as well. So I alluded to the fact that the neurosurgeons and neurointensive cares have some other options available to them that we unfortunately don't have. So patients, for example, at Queen's might have an EVD, a ventricular drain put in, and that allows monitoring of the pressure within the ventricles and a direct reading of the ICP. So for patients, for example, who have had a subarachnoid hemorrhage and who might have a hydrocephalus with a clot sitting somewhere, that might be a life-saving intervention. The other monitoring interventions that can be done at Queen's is to put in a bolt. So a bolt is a hole that's drilled in the skull, and a pressure transducer is put through that, sits in the brain parenchyma, and gives a direct reading of the pressure oscillations within the brain. That gives a reading of ICP. So when I've talked about trying to ensure that patients sat up to reduce ICP, or that the MAP's adequate, using these interventions really allows us to see exactly what the ICP is, exactly how well we're perfusing that brain. So some centres have monitoring that we just don't have access to here. Within our trauma network, patients that have had polytrauma by definition should be transferred anyway, and definitely a head injury in the context of other trauma should be transferred to Queen's. We touched on the subject of intubation and whether we should intubate the patient. The AGBI, or the association guidance, has some specific words on what we should do with those patients, and specifically on the staff that should transfer. And in general, you should certainly always have someone with the capability to manage an airway, or provide advanced airway management on trauma and the ability to do that. So you would have an anaesthetic or a pair of competent anaesthetic hands going with that patient, with somebody that could provide skilled anaesthetic assistance. Arguably, that's probably going to be easier to achieve in your base centre when you've got an ODP available and you've got help. So my preference would almost always be to intubate these patients, partly for stability and partly because you can get the patient in the right position, and it's just easier than doing it in the back of an ambulance, and it's probably safer for the patient as well. When you do intubate these patients, you want to know pre-intubation GCS, you want to know any neurology, you want to know if there's any fits, and the results of your primary and secondary survey. So what else is going on with that patient? What do I need to hand over to your neurosurgical centre or to your trauma centre? The other things to think about when you're dealing with the head injury, particularly in UHL, is that you're going to want those images transferred across to the trauma centre as well. That should happen as a matter of course, but it is something that needs to be done manually by the radiographers. When you put the tube into these patients, it should be taped and not tied. So the reason being to reduce your CVP and that pressure to again reduce the chances of the secondary brain injury. I've mentioned pressor response on this slide as well. So as we said, when you try and intubate a patient, you normally have a pressor response, so a very hypertensive patient in response to the laryngoscope going in. When you're managing a trauma patient, you really want to ablate that as much as possible. So I said that you lose cerebral autoregulation in these patients, so the perfusion pressure is directly proportional to the MAP. And you want to keep a stable MAP, you don't want it to shoot up. You need to use an opiate of some kind to ablate the pressor response. And if you think through to the context of your rapid sequence induction, you want something that will go away again quickly in case you have an issue with failed intubation, although realistically these aren't patients you're going to want to wake up. Everyone has their own mixture for what works for them. Some patients will use a very heavy fentanyl based anaesthetic, which should provide cardio stability, but equally will obtune the patient, and you're not going to be able to reverse that quickly. Some patients, some people will use a very heavy alfentanil base, which would be my own preference, because it works quickly, quick onset, and it goes away very quickly. Always backed up with some phenylephrine or some vasopressor to try and maintain as much stability as possible. Stability is the key. In terms of your induction agent, in all honesty, it probably doesn't matter. Something that you're comfortable with, something that isn't going to give an alpine anaesthetic with great swings in blood pressure. Ketamine used to be a great no-no because of the thoughts of increasing intracranial pressure. It's probably not as much a no-no now as it used to be, because it does preserve your MAP and it does preserve your perfusion pressure, but it does lower seizure thresholds. So my preference would not be to use ketamine, but it's not, if it's something you're very familiar with, it's not something that's absolutely contraindicated, but it's not something to pick up for the first time in these patients. And then the final part of intubation, it's about using an appropriate muscle relaxant. And again, it probably doesn't matter what you use between rocuronium and succinylthonium. In terms of preparing for transfer, so all of your standard AGBI Association minimum standards of monitoring apply for transferring an intubated patient. Other things that I really think are important in the head trauma operation are to site an arterial line, because you do want that beat-to-beat blood pressure monitoring. There's no doubt about it. Juggling around in the back of an ambulance causes non-invasive BP to fail and not work quite as well as it should do. Urinary catheter, it seems like a really small thing, but if you end up giving mannitol or hypertonic saline in the back of an ambulance and the patient gets raised intracranial pressure because they've got a full bladder, that's potentially a cause of secondary brain injury. So there should always be someone in ED who can help with catheterizing that patient. When you're thinking about and planning a transfer, and it's in the association guidance, you need to know who you're transferring to and a way of getting hold of them. So if you're transferring, you should go with a mobile phone. You should have numbers for both centres. And For sort of local advice, if you're going to Queen's, you want to know, are you going to the intensive care? Are you going to the straight to the theatre suite? You want to know where you're going, really, because our local centre, Queen's, is a big place and it's quite easy to get lost. And you need to find someone who can get you to the right place. You don't want to be stuck in a corridor running out of oxygen. You want to know who to talk to about complications. So who do you get advice from if you're racing down the M1 and the patient's coning? Emergency advice generally from the neurosurgeons. You want to be looking at the pupils throughout the transfer, and if you get a sudden change in neurology or pupils, you'd be calling them, asking them what their preference is. And it's generally because the intracranial pressure's gone up. So if you've done all of the things right, if you've maintained good perfusion pressure, you've taken steps to reduce the intracranial pressure, and you've still got a change, the surgeons need to be aware of that, and they will usually advise you to do something to reduce that pressure. In the olden days, it used to be to hyperventilate, which they might still do as a rescue measure these days, but more often than not, it will be either to give mannitol or hypertonic saline. UHL recent policy is towards hypertonic saline, 2.7 cents, 3 mils per kilogram over 20 minutes, and that's our current guidance. ED have a useful performer which sort of matches the weight to the amount and infusion rate that you would have to give that patient. And if you're going on a transfer as well, we're taking one of those with you. Mannitol is the other option, and that's what we used to use. It's 0.25 grams per kilogram over 30 minutes. The problem with mannitol is that it's quite temperature sensitive and it crystallizes out, and once it's crystallized, you can't use it. Ambulances are either like ovens or fridges, so it's not necessarily the most reliable drug. But if you've got a patient who is has raised intracranial pressure and you're having a complication with, I'd always seek neurosurgical advice, because they're ultimately the people that are going to be managing that patient going forwards. So we've talked a little bit about what we would do to manage raised ICP. I spoke earlier about the fact that some of our neurosurgical colleagues have access to some additional therapies which might be useful and some additional monitoring. We sort of get down to about this point in UHL, and then beyond that we struggle. There's nothing else that we can really do. But I thought I'll try and highlight some of the other things that can be done in the case of refractory raised ICP. So some of these interventions are taken from Nottingham's guidance. So the basic things we've talked about: having the bed angled upwards, avoid impairing venous drainage, ventilate to normal CO2, avoiding hypoxia, avoiding coughing. You still get raised intracranial pressure despite that. You give mannitol or hypertonic saline. You can paralyze the patient so they're not coughing or straining against the tube. And then there's other things that we can do. So in Nottingham, for example, they would look to provide burst suppression. So the idea of that is really to reduce your CMRO2 and to reduce any hypoxia and to maintain adequate perfusion for that brain. Hypoxic brain is a brain that has a high intracranial pressure. And they do that by running thiopentone infusion. But you can't just run your thiopentone infusion. You have to be monitoring continuous EEG with telemetry in order to see what's happening with that patient. So in the same way that those of you that are anaesthetists and have perhaps done TIVA with our Massimo monitors, you can see if you've over anaesthetised a patient, and they'll have a flat line on the EEG, and that's either that you're not perfusing the brain or you achieve burst suppression. So that's you've gone too far with the TIVA. In raised ICP, that's what the intention is, and provided you're perfusing that brain, a flat line is going to be burst suppression, and that's the medical management that they would do at Queen's. I mentioned about decompressive craniectomy, and that is a rescue therapy, which is a sort of very much consultant neurosurgeon type decision. So that's lifting a piece of skull off the patient and allowing that brain to decompress itself. More about that a little bit later on. And then finally, I talked about CSF drainage. So thinking about the three things you've got in your brain, in your skull, you've got blood, you've got brain, you've got CSF. We talked about reducing the blood by all of our vascular interventions. We talked about removing the fixed box so you can allow your brain to spill out. Removing the CSF is the other option that can reduce the intracranial pressure as well. Again, in a very controlled way. If you think back to the traditional medical teaching, if someone's got raised intracranial pressure, you wouldn't do a lumbar puncture. You would very carefully restrict the amount that you remove via the EVD, and that's why that has to be done in a neurosurgical centre with continuous monitoring. So beyond our standard therapies, there are a few things that can be done, but they're very specialist, which is why these patients need to be monitored in a specialist centre. So in terms of monitoring, I mentioned that you can monitor the intracranial pressure. So you do that with a bolt or you do it with an EVD. The other things that you can monitor, as I said, are the EEG or the CFAM or process spectral array. So these are partly to allow you to manage and prevent secondary complications of the patients, but they also can have some kind of a role in prognosis as well. So you may have seen patients on our own unit who perhaps come in after a cardiac arrest or a brain injury and they're not waking up. So we then go down the route of, well, we'll do an EEG and see what's happening, because sometimes patients don't wake up because they're fitting or they've got subclinical status. So an EEG can be helpful for telling you what's going on and allowing you to manage that. It might also show something else like severe encephalopathy, and it might give you that as something which might herald a poor prognosis for that patient or generalized cerebral dysfunction. So it will give you those things which can help you work out what's going on and whether there's anything to do to optimize this patient, or whether this is how they're going to be and they have a poor prognosis, or whether they have any neuro rehab potential. And as I said on the previous slide, the other thing that you would use EEG and CFAM for is to facilitate burst suppression in your managing of refractory ICP for those patients. Even the best managed patients develop some complications, and as part of the physiology of traumatic brain injury, there are a few things that you should be aware of and should look out for. So Cushing's reflex we'll talk about. You can get all manner of sodium abnormalities, which causes a lot of head scratching and what to do with. And then vasospasm is a particular problem for subarachnoid hemorrhage. So talking about the Cushing's reflex, really classic. Certainly a lot of medical teaching and will come up in various medical exams and anaesthetic exams. So it's a sign of raised intracranial pressure. And if you get your patient that's very hypertensive, that's because they've got raised intracranial pressure and they're trying to increase their cerebral perfusion pressure. They can become very bradycardic, and that's partly because they've driven such a high NAP. To do that, that's also partly because of pressure on the brainstem. And they develop abnormal respiration as well, and that's because of pressure on the brainstem. If you've got someone that's showing Cushing's reflex in front of you, they're coning, they've got pressure on their brainstem, and they are about to develop an irreversible brain injury. And arguably, things are probably futile if they've reached that point. Sodium abnormalities, always a cause of much consternation. So in general, diabetes insipidus, cerebral salt wasting, or SIADH. Diabetes insipidus is probably the more common type of sodium abnormality that you have. It's an insensitivity to or deficiency of endogenous ADH. We don't really know why it happens, but patients develop very high urine output. They end up peeing out a lot of their sodium essentially, so they end up hypovolemic because they're losing a lot of their water. They lose sodium in their urine, and remembering back from your renal physiology, water tends to follow sodium. So they develop a low urinary osmolality because they have a really dilute urine which is bursting with sodium, and they have a high plasma osmolality because they're losing free water and sodium. Treatment for that is to give DDAVP. So patients don't produce their own ADH, so you effectively give DDAVP to reduce that. Patients can get renal loss of sodium through cerebral salt wasting as well. So those patients, in a similar way to diabetes insipidus, are hypovolemic. they have a high urinary sodium. Difference is that they have a low plasma osmolality, so they lose sodium, but their osmolality, plasma osmolality, stays relatively similar. Finally, SIADH, which can happen with brain injury, but it tends to be more associated with brain tumours, sort of endocrine type tumours. And patients have inappropriate secretion of antidiuretic hormones. So they have an inappropriate antidiuresis, which means they're not sort of trying to lose all of their water. They tend to retain water, so they're in the normal way. So they'll be euvolemic or hypervolemic. They have a high urinary sodium because they're retaining water and they're not losing free water. They have a high urinary osmolality, again because they're not losing water, and a low plasma osmolality. They just don't get that thirsty. So the treatment is treatment is fluid restriction for that. So you sort of work out what's going on by looking at urine and serum osmolalities and making an assessment of whether the patient's hyper-euvolemic or hypovolemic, and then looking at the likely pathology based on what's going on with the patient. The reason it's important to control the sodium in these patients is that high or low sodium in itself can be a cause of derangements of consciousness, and it's a requirement for brainstem death testing if we have a patient who we think has brainstem death. I mentioned vasospasm as well as a cause of neurological deterioration, and vasospasm in particular is associated with subarachnoid hemorrhage and subaneurysmal disease. The blood can be quite irritant, and if you've got a patient who is doing relatively well, they can have a delayed neurological deterioration where they get vasospasm, and then the area distal to that blood vessel becomes ischemic. It can happen at day 7 to 10, so this isn't the patient who initially presents with your classical history of a subarachnoid with a thunderclap headache and suddenly falling over. This is the patient who's perhaps had their aneurysm dealt with, coiled or clipped, and then later deteriorates on the ward. Certainly had a few patients who suffered that at Queen's. So those patients typically get modipine as a calcium channel antagonist. They get that regularly to maintain their levels. Sometimes the interventional radiologist can do catheter-directed vasodilator therapy as well in order to reduce vasospasm. So it's a significant complication, and there might not necessarily be anything on the CT scan, but they do need a CT angio in order to see what's going on, and they do need to be started on the modipine in order to reverse the vasospasm. So we've talked about some complications, things to think about. I'm now going to talk a little bit about definitive management. Your patient with your brain injury, they get whisked off to Queen's, and then Queen's sort of do something in their magic box and send the patient back to us for neuro rehab. I mentioned about decompressive craniectomy. As I said, taking a piece of the skull out to enable the brain to decompress, pretty much only in MCA infarcts. There were a couple of trials that showed that decompressive craniectomy, although it improves survival, doesn't improve neurological outcomes in patients with other conditions. So effectively, you end up with people living longer but more disabled in a state that they wouldn't want to be in. So it's not something that is generally offered outside the context of MCA infarcts, malignant MCA infarcts, I should say. Shunting. So if you've got someone who's got raised intracranial pressure due to a hydrocephalus from perhaps either an obstructing brain tumour or in the context of this, a clot that's sitting in their ventricular system, putting in a shunt can help. So a VP shunt might reduce the pressure, as can an extraventricular drain as well. But evacuation is the mainstay of treatment for most of our patients who've got sort of intracranial injury. And the typical is a burr hole, which is a hole drilled through the skull, and literally any clot or blood sitting there is suctioned out in order to give space for the brain inside there. Neurological management is sometimes conservative, so sometimes patients just go to Queen's or your neurocentre just so they can be observed and have that additional monitoring that we just simply can't offer outside of that context. Or they might have the evacuation, which, as I said, might be a burr hole, or it might be a craniotomy, So taking a bigger piece of skull out in order to get to the clot and take it out. All of that's fine and reasonable, but it depends on where your clot is. So as you saw on some venous images earlier, a lot of the clots are peripheral. And if you think about the pathology of subdurals, for example, tearing of bridging veins, that's most likely to be peripheral. If you've got bleeding into the deep parts of the brain, to the brainstem, into I think areas like the thalamus or the deep nuclei, you can't get to it. And so actually those patients are more likely to be managed conservatively, and they're more likely to have a poor outcome. If you have a bleed into the brain and that affects the consciousness or the sort of very fundamental parts of that person's homeostasis, they're probably not going to survive. That's why brainstem lesions are so devastating. Your patient with a traumatic subarachnoid hemorrhage. So generally, you're managing them symptomatically. You're treating complications. You're trying to drain any blood and prevent them from getting any hydrocephalus and treating vasospasm. So they have an EVD put in. They might have a shunt and any treatment of vasospasm a bit later down the line. So talking about some controversies. So the three more later bits of research I'm going to talk a little bit about. So decompressive craniectomy. Now I mentioned that decompressive craniectomy is now pretty much only in malignant MCA infants. So that was after the Rescue ICP trial, which just simply showed that those patients might survive for longer, but they tend to be more disabled and tend to have a poor outcome overall. So the guidance is that they really shouldn't be offered that therapy. And DECRA, which was another trial looking into the same thing, showed similar. Again, these trials are sort of relatively topical and trials that may come up in something like the FICM or the final CA. Crash, everybody loves a bit of tranexamic acid, and TXA is safe in traumatic brain injury and does reduce deaths if given within 3 hours. So we should be giving it as part of our management of traumatic brain injury. Crash 3 trial, I think, published within the last couple of years. So the elephant or polar bear in the room is therapeutic hypothermia. I haven't mentioned that because we don't do it anymore. When I was kind of SHO, we used to pretty much cool all of these patients and achieve a temperature of less than 35. Hypothermia was always interesting. These patients always had a lot of shivering and various cardiac abnormalities, and it's probably more of a relief that the latest trials like POLAR have shown that intentional therapeutic hypothermia doesn't do any good and doesn't have any benefit, and those patients have significant issues with ECG changes, and you increase their metabolic rate by making them shiver, and you often had to paralyze those patients because they were shivering so much. So whilst we don't actively cool patients anymore, we do prevent them from becoming hyperthermic. So generally we would allow the temperature to drift, but if you had a pyrexia, you would actively cool, or you would set your Arctic sun or your polar air to avoid temperature of above 38. And again, similar things apply. If you had your patient that was shivering, you would want to try and stop that. So you might end up either sedating them more or paralysing them. The problem with paralysing these patients is that once you do that, you don't see if they're fitting. Okay, so on to the final bit of the talk now: who to admit and how to prognosticate. So this is the Dalai Lama, who talked about the 3 R's, which are respect for self, respect for others, and responsibility for your actions. So I think in terms of ICU, the important R's that we should be looking at are reversibility. So does the patient have a pathology that's reversible? If they have a big bit of blood sitting in their head in an area that's accessible, then potentially that's a reversible pathology. Recoverability. What was the patient like beforehand? If they weren't an ICU candidate before they developed a head injury, then they're not going to be an ICU candidate afterwards. So baseline functional state is really, really important to work out whether the patient's likely to survive overall, whether it would be reasonable to offer ICU. And finally, you should have a reason to admit. I'm probably going to be a little bit controversial, but during my time in Nottingham, I was told that reasons to admit patients to ICU were for diagnosis, for treatment, palliation. So it may be that you don't know and the patient ends up receiving palliative care in ICU. I think going into the future, we'll probably do much more palliative care as part of our ICU training. And I think it's important to give somebody a good death. So there are some patients who end up coming for palliation. Hopefully not many of our patients. A lot of our patients come because they need to come to us for support of blood pressure and oxygenation and to avoid secondary brain injury within this context. But these are the things to think about when you're considering. These are the things that I think about when I'm thinking about whether to admit someone. Prognostication is really, really, really difficult. There's a document that's been produced by various learned societies, the Effective Intensive Care, the ICS, and NACS, who are the Neurosurgical and Critical Care Society. So this is a series of guidance on what we should do if you have a patient with a devastating brain injury. And essentially the current guidance is really if the patient is likely to benefit from ICU, provided the scan isn't catastrophic, they should probably come to ICU. The guidance recognises that it's very difficult to prognosticate early in the patient's stay, and there aren't any really, really good markers. Things that are likely to herald a poor prognosis include a low motor score on the initial GCS, which is why that GCS and the breakdown is really, really important. If you've got someone in status that you can't control, that's a bad sign. If you've got someone with persistent myoclonic jerks, that's a bad sign as well. And if you've got someone with fixed eyes, pupils, it doesn't take a genius to work out that's a pretty bad sign. So you can admit someone to ICU for prognostication because you don't know less than 72 hours how the patient is. And the guidance is that we should probably not be prognosticating before 72 hours. And there are certain states where we might need to wait for longer or look for other tests. So, for example, posterior fossa pathology. We can admit patients for treatment and neurological monitoring, and we can't do that, but a neurosurgical centre can. We can admit someone for palliation, or we can admit someone for organ donation. And we shouldn't be admitting someone just for the express purpose of organ donation. We should be admitting patients because we don't know prognostication, because we think they'll have a good outcome. But it may be that the patient stays with us and they end up being brainstem dead, in which case we should be offering organ donation, and we should be working together with our specialist nurses for organ donation to evaluate the patient and offer any appropriate intervention in line with their wishes. I mentioned at the beginning that trauma is the leading cause of death in the under 40s. So many of these patients may be good physiologically, and they may be in a position where they could do some good and donate. So I feel strongly that we should be doing this. So in summary, patients that come into UHL with a traumatic brain injury, we should be transferring from monitoring or definitive treatment. We should admit them for prognostication if not contraindicated. So thinking about those 3 R's of reversibility, recoverability, and having a reason to admit. The general principles of managing secondary injury are all about maintaining normality, and you won't go far wrong if you try to keep the physiological state normal. But before I finish, does anyone have any questions?
Don't seem to. I was going to say, when you're talking about the Cushing's reflex, that I've rarely seen patients that go hypertensive and bradycardic. They go hypertensive and you get the GTN out, and then they go hypotensive and you get the NORAD out, and then they go straight back again. And they end up with various arrhythmias of whatever that might be. They go bradycardic or tachycardic.
Oh, I think that's just pressure on the brainstem.
Yeah.
Yeah, it's horrible.
And they rarely get the hypertensive bradycardic thing, but if they become cardiovascularly unstable, then you can be pretty sure that they're coning. That's all I was going to say. Has anybody got any questions? Kaya?
I don't think that's a question per se, but I found managing patients with low GCSs very difficult in ED, especially post-trauma. I think there's a different category if it's a post-trauma and the young patients, and obviously they need immediate management. I think the thing starts to get really complicated when there's a patient who's elderly and they fall and they've got a head injury and they are post-cardiac arrest. And then the decision about the intubating, non-intubating, quick transfer to the CT scan, further management plan. I think because of the patients getting so many comorbidities, they get frail as well. It's the decision about putting the tube down and not to intubate the patient. It's much more complicated. I think this is totally, different subject, different category of the patient, but that's something that I think we see more and more often.
That's what I think ED calls silver trauma, and I agree. It's complicated, and it's sort of it's almost falling into a category in its own right, or especially in its own right. So one thing I would say about putting a tube down is you can always take the tube out, and actually, if you need to do it to prevent the patient aspirating, that's probably not an unreasonable thing to do. You can always take it out, although you and I both know that doing that in ED is sometimes challenging.
You need to try and work out whether you'd admit the patient if they had anything else wrong with them or whether you wouldn't, which involves talking to the family and making sure you've got a proper history, working out whether they will survive the ITU outcome, whether the recoverability part of the ER, and don't be afraid of phoning the boss.
I think that's absolutely. I think that's the spot on what you've just both said. That but it's a process and it takes time, and I think that that for me at least to align the priorities in those circumstances is very important, and also teamwork, isn't it? So there's things that keep rolling. That you're not the only person who deals with this patient, with family, and organize all the transfer and sorting everything out. Yeah,
definitely. I think that maybe other specialties don't always realise that for us to say no, it's a lot harder. But yeah, that's true. Paris?
Yeah, the one that I find annoying is when you've referred a patient to neurosurgery and they say, well, the GCS is too good, and then they drop a GCS point and you call them back and they say, no, sorry, it's too late. Those are the ones I find the most frustrating ones, to be honest. Again, it's not a question. I don't think there's anything we'll do about it. And like Chris said, it's best to put the tube in and start treatment. And then, if the prognosis ends up being bad, then at least you can take the tube out at that point. But I've seen it so often where, unless the GCS is 12.75, they're not going to get admitted to neurosurgery.
GCS isn't always great because it can be variable depending on who's done it. It's a bit subjective. But yeah, sometimes, as Chris said, the motor score is actually the most important part of the GCS. So you can always emphasize that. If somebody's just not talking and not opening their eyes, it's not as important as somebody who's extending to pain, for example. So you can always emphasize that if they're being difficult. But yeah, there's not much that you can do necessarily from to encourage the neurosurgeons to take a patient, to be honest, unfortunately.
I think, having worked at Queen's briefly, it's almost reassuring to see that actually, even when they're on site, it doesn't necessarily affect their decision making, and they're still quite inconsistent even between neurosurgical registrars.
Yeah, that's true. It was just as bad working on Queen's ITU as it is in Leicester, to be honest, which makes you feel better, I suppose.
The other comment I was thinking about is about GCS itself as like you mentioned already, Zoe, that it's not always the best marker, although it gives you a number. And I feel like GCS is great for this situation with traumatic brain injuries or traumatic head injuries, but quite often we see it being quoted for all sort of loss of consciousness, all sort of drop in CNS levels, and in which case it gets a bit confusing in terms of when should we be using GCS and when we shouldn't be. But I feel like we use it for everything now to describe any sort of drop of consciousness. I think we overuse it probably. I don't know what other people think.
I would agree. Paramedics like documenting it very carefully when the GCS is 3, when the patient's been tubed pre-hospital and is on sedation. When it doesn't actually, GCS when you're on sedation doesn't mean anything. And you shouldn't be writing V1 anyway, you should be writing VT technically. And it can be affected by lots of things. We get lots of the patients that we see in A&E have been taking drugs or alcohol or whatever, and so their GCS is partly affected by that. That makes it more difficult. Unfortunately, we don't have another school really. You can do AFPU, but neurosurgeons won't be happy with that. Or you can do a CT scan and then use the other various different scores that are dependent on the CT imaging. But
again, I don't know what other people think, but I find that I see a lot of patients in A&E with a GCS of apparently less than 8 who are lying there on their backs with no sort of airway support. I feel like we've also forgotten what a recovery position is. Again, this is not relating to traumatic head injury, but per se, although you can still put a patient in a recovery position even if they have a traumatic head injury. But yeah, the number of times we've gone down, they're flat on their back, snoring away, and there's not even anybody standing there. And as soon as you walk in, there's definitely not anybody standing there. Again, it's just
that does happen.
Annoying.
Yeah, the lack of recovery position upsets me as well, Paris. But nobody ever wants to turn anybody on their side for some reason. I don't know why. I think we should do it as well, to be honest, when we're doing palliative care and we're extubating, and we're discussing whether the patient will obstruct when we take their tube out. We can just put them on their side and turn them towards the partner or the rest of the family. They don't have to lie on their back. It can be an option to do that. Kaya?
I think that, I agree with you, Paras, that, the assessment of GCSs is far from perfect. I think sometimes, I still remember actually in terms of the GCSs, how to do it. I've learned in ED when I was an ED trainee, but a different life. But the question that I had from the consultant who actually talked about the GCSs, what I think needs to be emphasized is the best response. So it's not what you see. You actually have to approach the patient and examine the patient properly. And, there are criteria to assess GCS. Answering. Pardon? Sorry?
Sorry, I've pressed unmute by accident. Don't worry, carry on.
The other thing is that I don't know why people don't like recovery position. I'm full for recovery position. I think it would make our life so much easier, especially with your snorers who are intoxicated. That's the way forward. Because if they vomit, they're just going to vomit on the hand, which that's what you want, and not going to the airways. But saying that, I had recently a patient who I put in the recovery position, and the nurses came in and they just sat him up, and the patient started snoring again. And it's like, I'm trying to help here, just showing you something that works, that is relatively simple. But I just think there's some sort of, I think we forgot. I think that's what happened. We forgot that there are those simple measures to manage the patient and just improve the ventilation pattern or airway obstruction, just putting them in the recovery position. Everyone wants to intubate the patient, you know, and do challenging things when I think do the very simple basic things first and then see what happens. It buys you sometimes time, if it's even 5 minutes, just to gather your thoughts. That's what I try to do. Take it simple, do your basics, and then think what's happening.
I would agree completely, Kaya. I don't know if Chris or Jenny would disagree, but that's what I've always taught people.
Agree. Do the basics well. That's intensive care in a nutshell.
Yeah.
Well, that's what I learned.
One of the other, sorry, I think one of the other frustrations that happens is sometimes you'll go down and do a GCS. This particularly happened to me when I was an SHO. And then you'll call somebody else to come and give you a hand to intubate. It's maybe somebody with a louder and more booming male sounding voice. And having had a GCS of 3, the patient then sits up and gives the male colleague a high five. That's quite frustrating.
Sometimes you just need time, or the patients need time.
I think that's probably an important human factors thing to think about as well. A few weeks ago, there was a patient who had arrested on the ward, and one of our registrars went up to go and intubate, and I got up there and everyone was standing around the patient, and the patient was going, "Get off me, get off me." And sorry, I've realised that's on camera. And pick someone else to stand back and say, "Hang on a minute, the patient doesn't need intubating," and it's really easy to get tunnel vision, to get really focused, and sometimes trying to take a step back when managing that sort of situation is really important.
Agreed. Does anybody else have any comments? No. We'll probably leave it there then. Thanks very much, Chris. And Hina, if she's still on the thing or if she's gone.